Hello, today I'm going to talk about root resorption. Can they be treated non-surgically? I'm Professor Hussain Al-Huwaizi from the Iraqi Endodontic Society. Many teeth may have external resorption or maybe internal resorption that will uh, affect the shape and the surrounding structures of the tooth. The tooth has protective layers against this resorption. Outer layer is the pre-cementum, whereby it prevents the osteoclasts from entering and eating away the root dentine. And in the pulpal region, we've got predentine, whereby it is protecting the dentine from odontoclasts. If the tooth is traumatized, it may undergo sclerosis, just like these two central incisors, whereby they are completely sclerosed to the apical region, but in this case, we have got big lesions associated with these teeth. In this case, we can see that one of the maxillary central incisors has got an internal external resorption. This condition is considered to be uh, difficult to treat, if not impossible. Trauma may be lateral or with the long axis of the tooth. It may be laterally, apically, or coronally, as can be seen here. Internal resorption occurs mostly in the middle area of the root canal. Now, to differentiate between external or internal resorption, like this resorption, we have to look at the continuity of the pulp chamber or pulp canal. If the pulp canal is continuous, that means this resorption in red, it is external. If it's the pulp canal, which is in green, not continued, in this case, it is internal. Classification of root resorptions, they may be external, internal, or pathologic. All of them are either inflammatory or due to trauma or cysts or tumors. External resorption may be a replacement resorption, whereby dentine and cementum replace the lost tissue, or inflammatory resorption, which is most aggressive. Internal resorption may happen due to many causes. Mostly and most important of all is trauma, just like this um, internal resorption case. First step in our treatment is diagnosis. For example, such a case had a maxillary central incisor with a blurry radiolucency in the middle third of the root. So I had to take a CBCT to verify what is this. I took the animated uh, X-ray, and I saw that there is misalignment of the occlusion. In the lateral view of the CBCT, I found that there is a huge external resorption that is associated with the pulp canal. This diagnosis is very important because it shows me if the condition is treatable or not. So, treatment. First of all, we have to do pulp extirpation, alkaline medicament like calcium hydroxide, alkaline irrigants as sodium hypochlorite or chlorhexidine. Here, the CBCT shows internal resorption in the maxillary lateral incisor and with a big lesion associated with it. So, first of all, we have to, of course, instrument, irrigate with a lot of ultrasonic vibration to clean the root canal and the internal resorption area. When we want to do obturation, as in this case, I flooded the root canal with bioceramic sealer. Then I placed a gutta-percha cone to the apical region to seal the apical region of the root canal. Then you can see that the master cone has sealed the apical area, and in the middle area whereby there is a space of the internal resorption, this space is unfilled. So in order to make the area of internal resorption be filled and push the sealer, I used a thermophil cone, a hot thermophil cone, and I placed it mesial to the master cone. And what happened is that this thermophil, or with soft gutta-percha, pushed the sealer laterally to seal the area. And this is a nice picture showing the complete obturation. Managing apical external resorption, you can see here that the apical region of this lower premolar shows apical external resorption of the apical area. Now the apex has been devastated. We don't know where is the minimum constricted area. That is why it is important to use the apex locator to locate where is the most constricted area, which may be quite far from the radiographic apex. Cases. This is a large lesion, a keratocyst with 5 necrotic teeth and extensive external resorption. Now, in order to ensure proper healing, these teeth had to be endodontically treated, and as this has been done, you can see the healing is very nice. Now you can see that this lower incisor has got a very short obturation. Really, it is not short, but the apex locator indicated that this area is the most constricted area. Now, it may indicate that there is a lot of lateral devastation of the root. That's why the root canal is not available, and the most constricted area is here. So we have to respect the apex locator and its recording. And this is, after a while, you can see the very nice healing. Case 2, a double internal resorption in the mandibular incisor with or associated with a periapical lesion. Now here we have to be very careful because after treatment, endodontic treatment, the tooth becomes quite weak, and we have to tell the patient to be very careful with this tooth. After a while, you can see that the internal resorption has been filled and the lesion has healed. And this is the protocol of treatment. Case 3, we can see here in the maxillary second premolar, the apical region has an obscure anatomy, and the root canal in the apical 2 to 3 millimeters has been lost. After treatment, you can see that there is a lateral canal and extrusion of sealer, indicating that the apical foramen has been changed here. Case 4, a huge periapical lesion with external resorption in the distal root of a mandibular molar. You can see that there is a certain extrusion of sealer and maybe even gutta-percha, but you can see after a couple of months the healing is very nice and it's undergoing good bone repair. Case 5, internal external resorption. This is a case or a patient who had this maxillary central incisor rather dark in color. Of course, we suspected it is non-vital. That's why we took a CBC. To see that there is a large internal external resorption that is lingually associated. Case 6, this premolar shows a lot of external resorption in the apical region. After obturation, we can see multiple lateral canals, and as expected, the most constricted area is quite far from the radiographic apex. After 9 years, you can see that the lesion has healed nicely. Of course, we are from the Iraqi Endodontic Society, and we welcome any member in this group. Anyone who is who wishes to see any cases, I've got my YouTube channel, which is called Simplifying Endodontics with Hussain Al-Huwaizi, and we have got many cases published by Endodontic Practice UK. And thank you very much.